Okay, so today what we're going to cover is musculoskeletal anatomy and physiology. A lot of this is review from the initial A&P review that you guys had in summer, but this is just a nice rapid review of some of the basic concepts associated with anatomy and physiology. However, a lot of this is kind of things that you tuck in the back of your mind, as the pants-specific material is not going to dwell on the anatomy, but it is good for your baseline knowledge. So I'm going to start my screen share here. Okay, so starting with the muscular system, quick anatomy review, the basics. So living organisms react to change. This is Newton's third law. For every action in nature, there is an equal and opposite reaction. Basically, stimulation triggers a response, either chemical, electrical, photo, mechanical. All of these responses require energy. Some of the apparati that are used in the human body may be cilia, flagella, or mitotic apparatus. This is an overview of a reflex loop. So basically, the thing to take home about these reflex loops is that the brain is not processing this. It's immediately processed in the dorsal root ganglion and in the spinal cord. That is the take home from these reflexes. So if the hand should come in contact with a hot object, we will pull that off without consciously thinking about it due to this reflex loop. Another thing that's good to take home for your neuroanatomy as well as your musculoskeletal anatomy is that the efferent axon is the axon that's exiting, and the afferent is receiving the signal. This is where the cell body is also housed for that afferent neuron. Where do muscle cells come from? So what is the origin of muscle cells? Well, they start in these things called mesenchymal cells in various locations throughout the embryo. So the origin of muscle cells is embryonic. And when we think about that, it's good to know that as an embryo, these muscle cells will change position from the start of that embryo to the final fetal development. And so some of this tissue may end up in different portions of the body. So we want to keep that in mind, particularly when we're dealing with malignancies or some other abnormality with an endocrinopathy, that some of these tissues, like say the thymus or somewhere in the brain, that some of those tissues may be related to other portions of the bodies that really are distal at the point now. But although in early development, those cells were in the same position and actually have the same lineage. And so that's sometimes why you'll see a tumor that may appear to be a thyroid type tissue that is in a completely different location. A lot of times that can be traced back to the embryology of that particular tumor. So another overview of the different tissue types. So you've got involuntary muscle, skeletal muscle, and then your smooth muscles. So the two being the cardiac and smooth muscle are under involuntary control, whereas the skeletal muscle obviously is under voluntary control. Look, I got fancy there. Okay, so what's the difference? Well, there's, structure and function are tightly entwined. So a lot of times the structure of a cell is going to indicate what the function of that, and then also adversely, right? So the function of something is going to also relate to the structure. So for instance, the cardiac muscle is going to have a different structure than a skeletal muscle because of its function. Same thing with smooth muscle. So let's look at some of these types. So skeletal muscle is usually long and cylindrical. It's multinucleated, as it's going to have the need for lots of oxygen. It's also going to have lots of mitochondria, which produce the energy needed for skeletal muscle movement. And it's going to be striated, and it's going to be under voluntary control. When we talk about cardiac muscle, we're talking about shorter and branched, uninucleated, striated, involuntary cells with intercalated discs. So they can still send signal through the cells, but they're not all one long multinucleated cell. And then smooth muscle is more spindle shaped, so thinner. It's uninucleated and non-striated and is under involuntary control. Skeletal muscles will attach to bones either directly or indirectly. Indirectly via a ligamentous structure or another muscle that they're anchored to. So the functions of these skeletal muscles include 5 primary functions, 1 being to produce movement of the skeleton, 2 to maintain posture and body position, 3 to support soft tissues, 4 to guard entrances and exits like sphincters, and 5 to maintain body temperature. So we'll go over some of those as we progress here. So here's just kind of a diagram on posture. Obviously, this gal in the middle has a wonderful posture, which you all have. And then you've kind of got these silly names that are just giving you kind of a guide to what that posture looks like utilizing a name here. So here's some of the sphincters. So sphincters are going to guard exits and entrances. So this is the gastroesophageal sphincter, and you can see how that muscle is going to block that exit so that the acid doesn't reflux up into the esophagus. One other function of muscle is to maintain body temperature. So this is just a little diagram of what a muscle or the muscular system could do to help regulate body temperature. So we get this stimulus of cold, right? The skin is cold, the body's cold. And this triggers receptors to sense that temperature change and then creates a response. And in this case, the hypothalamus stimulates the nerves to relevant body parts, causes us to increase heat production and decrease loss. If this is inadequate, then shivering will occur to increase the heat in the muscles and therefore increasing core temperature in the body. What is the gross anatomy? So gross anatomy is going to include your connective tissue organization, meaning the epiphysium, which is a fibrous covering over the entire muscle, the paramecium, which is a fibrous covering over one fascicle, the endomecium, which is a fibrous covering over a single muscle fiber, and then the aponeuroses, which is the tendons. So let's look at this. So here you go. You've got the outer covering over this bundle of fascia or muscles, and that's called the epiphysium. And then internal to that, you have this paramecium. And then when you're going to discuss a single nerve cell, you've got this endomecium, which covers the single skeletal muscle fiber. So that's just kind of a going from large to small as far as these muscle fibers are concerned. What is the microanatomy of the muscle fiber? So this is when you get into kind of the weeds here with muscle contraction. They talk about the Z discs and the M line and the overlap. And this is really basically how the actin and myosin are able to be understood and how muscle contraction truly works. So when we're talking about this, we're talking about the microanatomy, the sarcolemma, which is the muscle cell membrane, the sarcoplasma, which is the muscle cell cytoplasm, and the sarcoplasmic reticulum, which is like the smooth ER. So it's going to transport calcium and store calcium. The transverse tubules, also known as the T-tubules, and the myofibrils, which is part of the contraction portion of the organelle, and then you have the sarcomeres. So anatomy of skeletal muscle includes sarcomere, or repeating structural unit of the myofibril. Parts of the sarcomere include monofilaments, thin filaments, thick filaments, Z lines, which anchor the thin filaments. And let's look at this, because it's difficult to just go over the words without seeing what's going on here. So here, the anatomy of skeletal muscles, and this is an organization of a single muscle fiber. So now we've gone all the way down to that single muscle fiber. And what you can see is these two tubules here, the terminal cisterna, the sarcolemma, the mitochondria, which it's going to be thick in mitochondria because it's got to produce a lot of ATP, and then your thin and thick filaments contained within the myofibril itself. So what I would like to do is include some videos that I think are really important for understanding muscle contraction and a little bit of a deeper understanding of the Z line and the actin and myosin interactions, as I think it's better articulated with a video rather than with a PowerPoint. And it's been difficult to transition from a PowerPoint to back to the video and then back to the PowerPoint. So what I'll do is I'll place these on the Heritage website and on YouTube as YouTube video links so that you guys can watch these at your leisure, and they will help enhance this lecture by far. So let's talk about the steps that start muscle contraction. So muscle contraction starts where at the end motor plate and also at the synaptic terminal. So the end motor plate is on the opposite side of the synaptic terminal and is actually the part of the muscle cell that's going to receive the signal from the synaptic terminal. The T-tubule goes down into the belly of the muscle and attaches to this sarcoplasmic reticulum, spreading the action potential and allowing for calcium release. So you can see the cell membrane. And then if we go through the steps of muscle contraction, it's going to be ACH release, binding to receptors. Then you're going to have an action potential that reaches the T-tubule. So this action potential goes down the cell membrane into this T-tubule, activates the sarcoplasmic reticulum, allows the sarcoplasmic reticulum to then release calcium, which triggers an active site exposure and forms a cross bridge formation. So it's really the release of calcium that tells the body, hey, it's time to make this muscle contraction. It's time to make the connection between myosin and actin, and that's when contraction begins. So then after that, ACH is removed from the site and reabsorbed back into the synaptic terminal. At step 7, the sarcoplasmic reticulum recaptures the calcium. And at step 8, the active sites are covered and no cross-bridge interaction is seen. Step 9, the contraction obviously ends, and at step 10, the relaxation occurs with passive return to resting length. Oops. Oops. Quick break here. Okay, back to recording here. Okay, so muscle contraction types. Let's start from the current slide. Okay, sorry about that little break there. Control of muscle contraction. So skeletal muscle fibers shorten as thin filaments interact with thick filaments and the sliding occurs. Okay, so the trigger for contraction is the release of calcium ions by the sarcoplasmic reticulum when the fiber is stimulated by its motor neuron. Contraction is an active process. Relaxation is the return to resting length. It is entirely passive. So muscle mechanics, what are some basic muscle definitions? So muscle tension, the pulling force on the tendons that muscle cells generate when contracting. Muscle twitch, a brief contraction / relaxation, muscle response to a single action potential. And then we've got these other terms, isometric, concentric, and eccentric. So iso means equal. It is basically an isometric contraction is where you're holding that muscle still, although the muscle is contracting, but you're not actually moving. A concentric contraction is when you're doing the work, and an eccentric contraction is when you are bringing it back down. So in this case, what it would look like is a concentric action is the action of raising up this muscle or raising up the arm while this rhomboid is contracting. As you hold it up there for a count or whatever, then the rhomboid is contracted, although the lever is not moving. This is considered isometric. And then as you relax the muscle and bring it back to its starting point, that's considered an eccentric contraction. So with a squat, if somebody goes down into the squat, that's eccentric. They're coming down, isometric as they hold, and then as they push up, they're doing the work. That is the concentric motion. So here's another way to just belabor this. So concentric, they're contracting their muscles. Eccentric, they are relaxing their muscles. And isometric, they are holding it steady. So the effect of repeated stimulation on muscle, and this is how we get into this tetanic contraction like with a seizure. So you've got stimulation, and as those series of twitches add up, they will create a tonic or tetanic type contraction where it is a totally stimulated muscle. So it's reaching the final threshold that causes this tetanus of the muscle to where the muscle is tight. What are motor units? So a motor unit is a small unit of muscle that is innervated by neurons. So we look at someone's calf musculature, we've got a calf muscle here, okay, and then there's the foot. So throughout that calf musculature, there are these small marks here that are going to indicate motor unit. Now, each motor unit is responsible for contracting a certain amount of tissue. Okay. So that's how that tissue type is innervated by these motor units that tell it to turn on or turn off. A motor unit defined as the motor unit and all the muscle cells that it controls is the unit. So you've got this motor neuron and all the muscle cells that are controlled by that motor neuron. Recruitment is to increase muscle tension by activating more motor units. So for instance, if I want to raise my calves up and this unit is not enough to produce that motion, I'm going to recruit more motor units to help me perform the motion of coming up onto my toes. Muscle mechanics. So some of this is analogous to that previous diagram that we saw with the reflex arc. However, it is slightly different. So these are under conscious control. So it cannot really be considered a reflex, but does still follow a lot of the same mechanisms. So we've got motor unit 1, 2, and 3. What happens is the body is always attuned to using as little energy as possible. So it's going to start with motor unit 1, and when motor unit 1 is not enough, it's going to trigger motor unit 2. And if motor unit 2 is not enough, then it's going to trigger motor unit 3. So these will all work together to produce the required or desired motion. A keynote to muscle mechanics: all voluntary, intentional muscle movements involve the sustained subtechnic contractions of skeletal muscle fibers organized into distinct motor units. The force generated can be increased by increasing the frequency of action potentials or by recruiting additional motor units. It's all about balance. Life is a balance. Energetics of muscle connection and contraction here. So muscle metabolism is displayed in this chart here. This is a muscle at rest, right? So a muscle at rest will slowly use fatty acids and release carbon dioxide, utilizing glucose as an energy source for muscle contraction and work. Okay. If the muscle is at rest, then this glucose that is in excess will be stored as glycogen. Okay. If the muscle is working and performing metabolic work, then we have to increase our oxygen supply and utilize glycogen to produce energy. So these glycogen stores are then released from the liver, processed in the muscle, broken down into glucose, and utilized for energy production. This is all performed in the mitochondria, with the waste product being CO2 and the final electron acceptor being oxygen, and finally producing water. The energy for all of this is derived from also fatty acids that are broken down in the mitochondria. And in the end, we end up with the production of ATP. If muscle contraction and metabolism takes place in the absence of oxygen, so there's no oxygen, no, Then we're going to produce fermentation, right? And that's when we produce lactic acid. So we're breaking down glycogen into glucose and pyruvic acid. And through another mechanism that we will not dive into at this time, we're going to produce lactic acid. The lactic acid is then excreted in the blood. Physical conditioning, right? So the more we work out, the bigger our muscles get, right? So that's called muscle hypertrophy. So if this guy works out every day and eats right, he's going to be super swole up, right? Because his muscles will grow to accommodate what he is doing to them and requiring them. Increase in muscle bulk can result from anaerobic training. What you don't use, you lose. And that is very true for muscle as well. So the anatomy of the muscular system, there's a whole bunch of different muscles. You should definitely be comfortable with all of these muscle groups, as well as the posterior muscle groups. Actions are important when we talk about muscles, and when we're examining patients, we need to know where most likely the discomfort is coming from, and we need to be comfortable with our anatomy. So origin is the muscle attachment that remains fixed, okay? Insertion is the muscle attachment that moves. So when we're talking about origin and insertion, the muscle attachment site that remains fixed and does not perform motion is considered the origin, and the insertion is the point of the muscle that actually moves. The action is what actual movement is produced by the joint. Here are some muscle anatomy of the face. I'd like you to just be familiar with these. We are not going to have specific diagrams that you'll be tested on. However, I want you to be comfortable with this verbiage and know where to get to this quickly, as it will be necessary in your clinical rotations. And then anatomy of the muscles of the head and neck, anatomy of the neck itself, as well as the main muscles of the face and skull. And then anatomy of the anterior neck. Here is the anatomy of the spine. She'll go into more in depth in the spine lecture. And then your torso or trunk. This portion is really something that you should be comfortable with, particularly for your surgical rotations, as you'll want to be comfortable with the layers of the abdomen, as these are things that you and the surgeon will most likely be cutting through, and you should be comfortable with this gross anatomy. These are muscles that are associated with the perineum, when this is a female anatomy. So these muscles are important in the pelvic floor or pelvic floor pathology, as well as with any rectal pathology or vaginal pathology. So we want to be aware of these and comfortable with the names. Here's the male perineum, the anatomy of the shoulder and back musculature, the anatomy of the anterior shoulder, superficial anatomy of the pectorals and deltoid muscles, and then the deeper anatomy of the posterior upper back and shoulder musculature. Rotator cuff musculature is something that you need to be very familiar with. These are the sits muscles, so the supraspinatus, infraspinatus, teres minor, and subscapularis. This is really good pimp fodder, as well as the upper extremity, which we will cover a lot of these more in depth when we get into the particular sections of musculoskeletal. But I think this is a good overview of where to start. And then the gluteals, gluteus medius, which is where a lot of injections are given. The hip musculature and the musculature of the thighs, and the muscles that move the leg, right? So make sure that in your time you kind of go over these. You should understand the basic actions of these muscles, and you should definitely be able to understand at least the most gross anatomy of these muscles. Toes and foot. All right, so going from the muscular system to the skeletal system. The skeletal system, we'll just do a quick overview, as this is where our muscles rest. So it is pertinent to the musculoskeletal system. Muscular skeletal. So what are the functions? Support against gravity, storage of minerals such as calcium and phosphorus and fat, blood cell production in the bone marrow, protection of soft internal organs, leverage for muscle action. What is bone? So bone is this osseous tissue. It's a specialized type of cell. 2% of bone weight is caused by these specialized cell. It is a strong, flexible matrix consistent with calcium phosphate crystals. 2/3 of the bone weight is made up by calcium phosphate crystals, and then we have these collagen fibers. And the macroscopic features of bone include the general shapes, such as the long bones, the short bones, flat bones, irregular bones. So here are some types of bones. So types of bones, and then some examples of those types of bones. So we've got our long bone, which is like the humerus and the femur, flat bone, which are the bones of the skull, the irregular bones, like the bones of the vertebra, and then our short bones, which you'll see in the carpal and the bones of the feet, the metacarpals. What are features of a long bone? Well, a long bone has this long shaft. It's compact, dense bone with marrow activity. So this is the location of bones of blood cell production. And then the epiphysis is the end with some spongy material of that bone, as well as articular cartilage. And then the coating of the entire bone is the periosteum. If we want to talk about the internal lining, there is one. It's called the endosteum, and we don't usually mention this as much because it's not of super high yield, but it is something that we should know. So let's look a little bit closer here. So here we've got this articular cartilage of the bone, and then at the end of the bone, you've got this spongy bone. This is considered the epiphyseal line. So this is where the growth plate closed. We've got the marrow cavity, and then the endosteum. This is compact bone here on the outside, and then this coating that covers the bone is the periosteum. So if you break it down grossly, you've got the proximal epiphysis, which is proximal to the midline, the diaphysis, which is the long part of the bone, and then the distal epiphysis, which is the other end. The structure of bone, what is the microscopic feature of bones? So as we get closer, we can see the periosteum and the type of cells that are there, the outer fibrous layers, intercellular layers, the osteocytes. The osteocytes are housed within the lacunae, which are the holes in the matrix, and between the lamina of the matrix themselves. So let's look at a picture of this. So here's the structure of a typical bone. So you've got that fibrous coating, which is your periosteum. You've also got blood that flows in throughout the bone. So it really is this living organ. You've got capillaries and then very small veins that will diffuse oxygen and nutrients into the bone. And then you've got this trabecular network of spongy bone. And you can see that the endosteum, this portion, is what separates the spongy bone from the more compact bone. And so these central canals are areas where the blood vessels come through, and a perforating canal is going to innervate with the trabecular or spongy bone. The structure of the bone is really typical here. We can see the lacunae, which are the internal portions, and then these concentric lamina, which are these circulating layers of bone that kind of finally go into this centralized canal. What are the cells in bone? So we've got osteocytes, mature bone cells between the lamina, and osteoclasts, a source of acid enzymes for osteolysis. Osteoblasts, which are responsible for osteogenesis, or the production of new bone. So bone formation and growth, intraosseous, intramembranous ossification. Okay, it's ossification process of converting other tissues to bone. So it's basically cartilage converting to bone, which we'll talk about. So bone formation and growth. So this is an intramembranous bones, right? So they're actually made of like a cartilage type material. These are endochondrial bones, so they're made of cartilage. Bone formation in 16-week-old fetus. So you can see that they're really starting to lay heavy calcium down, and these bones are really starting to progress. So let's see. This is a diagram here that kind of generally goes over the formation of an adult bone or a mature bone. So at first you've got chondrocytes, which are your cartilage growing centers of the bone. So this is a cartilage model. And then eventually we start to get osteoblasts, which cover the shaft of the cartilage in the layer of bone, and you get this thin layer here. So this is kind of what you saw in that fetus. And then as this progresses, we get more and more compact bone and spongy bone that lays down. So bone formation and growth. So if you look at an infant, they've got some of this deposit of osteoblasts. And then in a child, you've got more of the spongy bone, and in an adult, even more. The bone is reabsorbed by osteoclasts. So what are the requirements for normal bone growth? Well, we require minerals in the form of calcium and phosphate, vitamins such as vitamin D3, vitamin C, vitamin A, and hormones that will affect bone growth, like growth hormone, sex hormone, thyroid hormone, and others. So growth hormone, what does growth hormone do? Well, growth hormone triggers us to grow, just as the hormone name would say. And what it's going to do is increase the growth of long bone. And also, as the body produces more and more growth hormone, we see closure of the epiphyseal plate. What that means is that the bones are not going to grow anymore in length. So when you see a growing bone, the epiphyseal growth plate is intact, which tells us that the patient has not gone through puberty yet, and that the epiphyseal plates are still actively making bone longer and longer. How does parathyroid hormone work with all of this? Well, the parathyroid gland is going to monitor serum calcium levels. And as those calcium levels decrease, then the parathyroid gland is going to kick out parathyroid hormone, which will regulate calcium release and phosphorus release. So as the concentration of parathyroid hormone in the blood decreases, that is a trigger, or sorry, as the calcium concentration decreases in the blood, that is monitored by the parathyroid, at which the parathyroid gland will secrete parathyroid hormone, which causes activation of osteoclast. And osteoclast will break down the bone, which in turn releases calcium and phosphorus. This will then increase the calcium level in the blood. This can also target the small intestine and the kidney to retain calcium and phosphorus so that we can increase our bone density. So vitamin D is also prevalent here, as vitamin D is metabolized in the liver and will then be stored in the form of calcidiol, which is responsible for telling the kidney to increase calcium reabsorption, as well as calcitrol, which will increase calcium reabsorption in the small intestine. What is the role of remodeling in support? What you don't use, you lose. The stress applied to bones during exercise are essential to maintaining bone strength and bone mass. Remodeling is a continuous breakdown and reforming of bone tissue. So basically, we want to encourage our patients that are elderly or at risk for decreased bone density to exercise, as the muscles are going to pull more on the bone, which is going to result in the remodeling of bone and making bone stronger. So what happens immediately during a fracture? So immediately after a fracture, there's extensive bleeding over a few hours, and a large blood clot or fracture hematoma develops, okay? That fracture hematoma then stimulates spongy bone and cartilage to start producing osteoblasts to start repairing bone. In step 3, the cartilage of the external calculus has been replaced by bone, and struts of spongy bone now unite the broken ends. Fragments of dead bone and the areas of bone closest to the break have been replaced. So we're basically remodeling that bone. And then in the 4th step, you'll see where that external calculus has enlarged that portion of bone, so we can see where the previous fracture site was. Overview of the skeleton. What are bone markings? Tuberosities, condyles, trochlea, facets, fossa, foramen, sinus, okay? What do all these mean? Well, they all really kind of allude to certain shapes of the bone. So even though we just kind of memorize these and know these actually kind of mean something. So like a trochanter, what the heck is a trochanter? We know that's the hip, right? But a trochanter is a large, rough projection, okay? What's a tuberosity? A small, rough projection. Tubercle, a small, rounded projection. So I don't know if this is anything that you really want to spend a lot of time on, but it is kind of interesting where we see like these foramen, which is a rounded passage for blood vessels or nerves, a fissure, which is an elongated cleft, and the sinus, a chamber within a bone, normally filled with air. So it is kind of interesting. The facet, the small, flat articular surface. So I think these are definitely of fairly decent yield for actual practice, but for testing purposes, we're not going to see a lot of this. So let's do an overview of bony surfaces. So here's some of those words, but just a picture to kind of shed some light on that. So a condyle, right? A condyle is this articulating surface. crest, fossa, tuberosity, head, tubercle, neck. So these are all really good words that we need to kind of have an idea about as they're going to define the anatomy and help us to conversate with people that know a lot more than we do about bones. So what are the skeletal divisions? So the axial skeleton, skull, thoracic cage, and sternum, vertebral column, the appendicular skeleton, which is your upper and lower limbs, your pectoral girdle, pelvic girdle, and here we go. So overview of the skeleton. So we've got these basic bones. We have to have a good idea of our facial bones as well as the bones of the skull and the suture lines themselves. I will let you do these at your leisure, but you should be comfortable with these. Just need to review this a couple times so that you get comfortable with it. The sphenoid sinuses. Here's our sinus passages, frontal, ethmoid, and maxillary. The structure of the sinuses provides a lot of strength as these are primarily oriented in a triangular fashion. Triangle disperses load very well and is one of the strongest shapes available for structure. That's why you'll see a lot of those on bridges, and the bridge of the nose is no different. This is a newborn and some of the suture lines. These suture lines should be palpable at certain stages of development. We can also use the coronal suture to assess for the hydration of a young child. There's that anterior fontanelle. That's where we're pressing on these newborns to see if they are hydrated. The vertebral column, which you'll go into in a lot more depth with Dr. DeMeo, but it's 7 cervical vertebrals as well as 12 thoracic vertebra with 5 lumbar vertebra. Then you have your sacrum, which is basically the foundation, and the coccyx, which is considered the tailbone. So here's the normal curvature of the spine. Vertebral column and thoracic cage. This is what a normal vertebra looks like. So you've got this vertebral arch, as well as the foramen, which is the centralized canal where the spinal cord comes down. You've got your transverse processes on the side, the superior articulating facets, which are these facets here, and that's where another vertebrae is going to articulate on top of it. The lamina, which you'll see laminar fractures, and then the transverse foramen. And that was a cervical vertebrae. Now the thoracic vertebrae looks a little bit different. You'll notice structure indicates function. So here we don't need as much mobility in our thoracic spine. So it's more of a linear looking vertebra with the same type of nomenclature. And then we have our more wider bodied vertebra, which are supporting more weight in the lumbar region. There are some particularly interesting vertebral components that we want to understand, the atlas and the axis. So when we get an odontoid view of a patient that we were concerned about a neck fracture, this is what we're looking at. We're looking at this dens. The odontoid process comes up. We want to make sure that there's no fracture here. So this is C1, which is the articulating surface for the skull, and then C2, which is going to sit underneath, but also has this dens process that comes up in the C1. The sacral region is the sacrum as well as the coccyx. And you can palpate this medial sacral crest on most people. And then we also need to realize that nerves come out of the sacrum and go down the leg and into the buttocks, particularly live kind of right under the piriformis, which covers them like this. And this is where basically people get what they call sciatica, because the sciatic nerve is inflamed and causing irritation here. What are the components of the thoracic cage? So you've got the thoracic vertebra, the ribs, 7 pairs of true ribs, cartilaginous joints with the sternum, 5 pairs of false ribs, the sternum, and we'll look at it from here. So here's the thoracic cage. So it starts at T1. You've got ribs will be numbered coming from here down. Rib number 2 is always that place where we think about doing a pause here for a second. All right, back to business. Sorry about that. I had a phone call and it was totally distracting me. So if we're concerned about some sort of pneumothorax or some sort of air in that lung space, then we can do needle decompression in this site. So we like to go above the rib as the van bundle sits below. So this is just some true ribs and false ribs, the anatomy there, as well as the costal cartilages. So here's the appendicular skeleton, the clavicle. We've got the sternal end as well as the acromial end, and then the facet there, which is a site of articulation with the acromion. And here is the shoulder blade with all the processes noted, the coracoid process, the acromion hood, the scapular spine, and the glenoid cavity, as well as the humerus, radius and ulna, the carpal bones and the metacarpals. And then here we get into the pelvis with the sacrum, ilium, ischium, pubis, and coccyx, which we will go more in depth as we move along throughout musculoskeletal. But it's nice to get kind of a gross overview at this time. There's the acetabulum, which is the articulating surface for the femur. The difference in the pelvis structures between male and female. Moving on to the femur, the greater trochanter, the articular surface of the head, and the neck of the femur. The right tibia with fibula shown there, lateral malleolus, medial malleolus, the articular surface. The bones of foot and ankle. So you've got your talus, which is kind of the central location where the weight is distributed into the foot, to the navicular bone, the cuboid bones, and the cuneiform bones. And then you've got your metatarsals and phalanxes. Here's the structure of the foot. Articulations. So we're talking about joints. So a joint is where 2 or more bones interact. There's 3 functional classifications of joints: synarthroses, are immovable, amphiarthroses are slightly movable, and diarthroses are freely movable. So when we think about a joint, we usually think about these very movable joints, but however, we need to realize that there's multiple different types of joints. So an articular surface is just that site where the cartilage interact and allow for movement. The joint cavity is the synovial fluid containing space between those two surfaces. Structure of synovial joints. Okay, so a synovial joint is a joint that contains synovial fluid that helps to cushion the joint and provide nice, free, lubricated motion. And you can see there with the kneecap, we've got the bursa, the fat pad, the joint capsule itself, the joint cavity, and then any ligaments that may be in that intracapsular space. What are the synovial joint movements? So they can do flexion, extension, hyperextension, abduction, adduction, circumduction, and rotation, which is pronation and supination. So let's kind of revisit that. So I would like to show those motions. Usually this is done in person, so I will show you with my pointer. So flexion. So let's take the elbow joint is a nice one to use here. So there's the humerus, radius, and ulna, and then there's our hand, okay? So actually, the best way to show it is in its resting state. So if this is the shoulder joint, this is the elbow joint, and the hand. Beautiful drawing, okay? And what we're going to do here is if we want to flex, we're going to decrease the, remember that all of the articulations start at the from the with the skeleton in the anatomical variant that that we start in is in the anatomical position. Now, so if you're in the anatomical position, that word totally escaped me for a minute, and you want to flex at the elbow joint, that is considered flexion, okay? Back at the anatomical position, if you are in flexion at 90 degrees, which would be this guy right here, and you wanted to then extend, that would be extension. And if you go beyond that point with this joint here, you're talking about hyperextension. So flexion of the elbow joint, extension of the elbow joint, and if you went past that into hyperextension, you would go back that way. Now, if we're talking about abduction and adduction, you're standing in the anatomical position. Here is our guy, okay? And we're going to go pick on this arm again. So if you're here and you're in the anatomical position and you're going to abduct, abduction, you're going to go away from the midline. And if you're going to adduct, you're going to add the arm back to the midline. So abduction and adduction. So add to the midline. Circumduction is when you would be able to move this shoulder joint around in a circle. So you could move like this. And a rotation is like a supination, pronation. So supination, I like to think of if the palm is up, you could put sup into that palm, and then pronation is palm down. So now the sup falls out in pronation. All right, those are so much easier when we're in person. So the anatomical position, you've got your different planes. So the sagittal plane is going to cut the patient right down the middle. The frontal plane separates them from front and back. And then the transverse plane is a transverse cut right through the patient. And then we can use our anatomical position to outline either up, down, side to side, and we use the proper terminology, which would be posterior, anterior from the anatomical position itself, and inferior, superior from the anatomical position itself. And sometimes we can use another joint to, like, if we're talking about the elbow and we want to say the pain is, you know, inferior to the elbow joint, that would be there. Or if the pain is superior to the elbow joint, then it would be up here, right? So we can use any joint to talk about these anatomical locations and directions. So we've got articulations at the foot and ankle, inversion and eversion. We'll go over these at the end. I'll just turn off the PowerPoint. Dorsiflexion, plantar flexion. So let me write these down because I want to take you through all of them. So we'll do flexion, extension, circumduction, rotation, and then inversion, eversion, supination, and pronation, as well as dorsiflex and plantar flex. And so those are some of the more vexing topics. In the hand, you can oppose the thumb to palm. This is that, you're able to oppose the thumb to the palm, pronation and supination. So the thumb would be one of those circumferential joints. And then the head, protraction, retraction, depression, elevation. And so here are some of the articulations. So eat your soup or dump your soup. So if you're supinating, you're going to put the soup in the palm of your hand. If you're pronating, you're going to dump the soup out. Here are some more. So this is at the knee joint here. So we've got flexion and extension of the knee joint. Here with the foot, you're seeing the foot in plantar flexion. If you were to flex these toes up, that would be dorsiflexion. And then from the body here, you've got abduction and adduction, as well as internal and external rotation. What are the structural classifications of synovial joints? So you've got gliding joints, hinge joints, pivot joints, and these distal radial joints, as well as saddle joint and a ball and socket joint. So just different types of joints. So here's some examples of articulations. So structural classifications of synovial joints. So the clavicle anchoring to the manubrium here is an articulation. This is a gliding joint, so it just slides kind of back and forth. You've got a hinge joint at the humerus there. The atlas and axis are pivot joints. You've got these ellipsoidal, ellipsoidal. Boy, that's a tough one. But these joints are basically joints that kind of articulate on each other. They will allow for full motion, but not a whole lot of motion. And then you also have these saddle joints, which a saddle joint really provides a lot of mobility, which is like your thumb joint. Other joints include the ball and socket joint, which doesn't have a lot of good stability, but provides you for high mobility. So the key is a joint cannot be both highly mobile and very strong. For instance, the shoulder, the greater the mobility, the weaker the joint, because the mobile joints rely on support from muscles and ligaments rather than solid bone connections. So the beauty of the shoulder is we can move it in many ranges of motion with a really vast range of motion. However, it can also dislocate because it is held in there by tendons and muscles and not bone on bone contact. So this is a anterior dislocated shoulder. You can see that the right shoulder obviously looks off, and these can be put back in with some skill. So articulations, intervertebral articulations is where the vertebra contact each other and have this light amount of movement. Other articulations include the shoulder joint itself with all of the joint capsule, the subdeltoid bursa, and other articular cartilages. Elbow joint here, a very complicated series of different structures that have all kind of come together to produce the function of the elbow and a whole lot of different motion choices for the individual. Here's another articulation. So this is the hip, provides a lot of range of motion, however, can become dislocated. The knee joint, which is more of a hinge joint. And that, my friends, is it. So let me end the PowerPoint, and I want to show you some of these articulations. Okay, so video is on me. Let's see if we can get some depth here. So the things that I wanted to show you, let me show my arm. So if we're talking about flexion and extension with a hinge joint, that's pretty easy, right? So if I'm talking about elbow flexion, elbow extension is coming from a flex point out, and then elbow hyperextension would be if I was able to hyperextend my elbow past that point of the anatomical position. So that's flexion and extension. Circumferential movement, you can see with the neck, there's usually multiple joints involved. Rotation, when we're talking about supination, so if you can set your sup in your hand, this is supination, so supinating the hand and wrist, and then pronating is to bring it down and out. So this would be supination, this is pronation. We also have, let's see, dorsalis, plantar flexion and dorsiflexion. So if we look at my foot here, let's see. So look at the foot, ankle here. So if you look at a foot, right? So the plantar surface of the foot is obviously the bottom of the foot. So if you're plantar flexing, you're going to flex down toward the plantar surface. And if you're dorsiflexing, you're flexing up. You can also invert and evert at the foot. So it's kind of confusing because it seems to be like a pronation, supination. So this is a supination, which is an inversion. And this would be a pronation, which is eversion when you're talking about the foot. I'm not actually sure why those are different, but they are. And so it is helpful for us to know that when we're talking to a specialist that knows more than we do about the foot and the ankle. And I think, oh, and then you can also do like shoulder internal, external rotation at the shoulder, internal, external. Remember that anatomical position is where all these come from. And then abduction and adduction. So you're adding it to the midline and you're abducting away from the body. And I hope that clears some things up for you and gets you on a good footing for the rest of musculoskeletal, as some of these more basic concepts will need to be understood before you can move to the next portion. I hope you're all doing well. Appreciate your time and energy, and I will look forward to completing the entire musculoskeletal section with you. Should be a good section. We should all have a good outcome.